Hey everybody, Dr. T here on a Wednesday, hump day. Hope you're having a good day. It's been cold again. I've got to say I feel the cold anyway. And when you've got no hair, you feel the cold even more. But anyway, we're here on a Wednesday and feeling good. A week post cycle 5 of chemo. So doing surprisingly well today. Big shout out to my dear friend, Dr. Kate Stern, who sent me some amazing makeup. So I've had a little play today. My eyelashes are still on. I've had to draw in my eyebrows a little bit, but I had fun. I had fun playing with makeup this morning. Thank you, Dr. Stern. I've got a couple of questions that have come through, but we're going to do a quick rapid fire Q&A. If you have any questions, please post them in the comments. Please try to make it short. Don't want to hear life story. And if you make it nice and generic, I'll give a generic answer, because what's the bet there is somebody out there else who is wanting to know the answer to your question. So I'll give guys some time to drop some stuff in the chat. Somebody has asked about exercise and IVF. What's the go? Look, the research around this stuff is not great. So my perspective on this is, if you have been an exerciser before, then I think it is really reasonable to continue with moderate level activity. So what would I call moderate? Let's say you are exercising 3 to 4 times per week, a little bit of huff and puff, that kind of intensity. It's not exercising every day, and it's not exercising at super high intensity every day. You need to reserve some energy for your body, and it is not a time to take up a weight loss challenge or a fitness challenge or anything like that. This is not the time for that. So if you've not exercised before, gentle, regular exercise can actually be really helpful. Now, I think exercise is a really valuable part of your mental health care management. So I do advocate it during treatment. It's really important. But maybe this is the time to be doing more mindfulness-based activities. So Pilates, yoga, meditation. I once had a mentor of mine say that you want to be doing the sort of exercise that you would be doing when you're 9 months pregnant. So I know we all see those videos on YouTube of the CrossFitter exercising at, third trimester of pregnancy. But honestly, for the vast majority, this is not the time, and definitely not if you are doing an IVF cycle. It can have a negative impact. Somebody else has asked about breastfeeding and falling pregnant. If you are struggling to conceive and you are still breastfeeding, it is possibly impactful. So it might be that you need to make a choice, or your child needs to make a choice. It's not ideal. We would not encourage you to go through IVF or even a frozen embryo transfer or even ovulation induction whilst you are still breastfeeding, because it is almost certainly going to reduce your chances of success. So generally speaking, the two are mutually exclusive. And I would certainly like, if you're coming to see me and you are wanting fertility treatment, or at least fertility treatment advice, the first thing I'm going to probably say to you is it's time to stop breastfeeding, or just wait to fall pregnant until you're ready to stop breastfeeding. Rach, what is the Bondi Protocol and why is it called the Bondi Protocol? So this has been termed by Dr. Gavin Sachs, who is somewhat of a specialist in the area of recurrent miscarriage and recurrent implantation failure. And so he's called it the Bondi Protocol, which includes, I believe, a combination of Clexane prednisolone treatment for people who have recurrent implantation failure, right? So then your question is, what is recurrent implantation failure? So there's various definitions, and I guess the most generic definition would be after the transfer of 3 good quality embryos and no pregnancy. So that would be the term. And then the question is, how do you determine what a good quality embryo is? Well, the best way is to make sure that they're chromosomally normal. So there are some advocates of the Bondi Protocol and there are some dissenters of the Bondi Protocol. It has never been tested in a randomized controlled trial. So that's the Bondi Protocol. And some people just practice the Bondi Protocol and call it something else. Okay. Christy Bunny, wait time for donor embryos at the moment. Well, it depends where you go, Christy Bunny. Donor embryos are hard to come by. They're very hard to come by. So months to years, my friend, to wait for donor embryos. Depends on the lab though. Rach, another question. You're on fire today, Rach. What happens to your AMH when you're pregnant? Do you still produce follicles? So your ovaries kind of go off to sleep when you're pregnant, kind of like when you're on the pill, because it reads those pregnancy hormones, those steroid hormones, and you don't ovulate. But are you losing eggs? Yes, you are. There's some historical research that looked at women who are on the pill versus women who are pregnant back to back versus women who are having menstrual cycles every single month. And their reduction in ovarian reserve is the same. So even when you're pregnant, your oocytes they've kind of all got a use by date. And so your egg reserve is reducing in those 9 months of pregnancy. Your AMH is, to be honest, I've never tested it during pregnancy, but biologically, I suspect it would be like when you're on the pill. So it would be falsely lowered in pregnancy. Good question though. All right, I have another question that someone asked before. What about this progesterone level after transfer? So we all pay very close attention to the progesterone after transfer and in pregnancy. I think that's actually where the question was going. How fixated, that's the word I was looking for. Sorry, chemo brain. We sometimes get a little over fixated on the progesterone levels. What you've got to remember is they're a blood level, they're a serum level. So we're taking a blood here. Sorry, just got a phone call. Pardon me. And we're measuring the blood, the impact of the progesterone at the level of the endometrium, right? And we're saying a certain level is going to determine whether a pregnancy will continue or it won't continue. I think the first thing is probably the pregnancy hormone is most important. So what is that HCG level and how is it rising over time? Then it's important to look at the progesterone level itself. And if the progesterone level is adequate with a well-rising HCG, do we really need to fixate on trying to give you more pessaries or more intramuscular progesterone when the pregnancy is continuing along okay? I think that's certainly very debatable. Is there a minimum where we would say, yeah, this pregnancy is going to fail? I don't want to put a number on it because there is some individual variability, but certainly levels where we see sort of less than 30 picomoles per litre of estrogen with a suboptimally rising HCG, that's when we would be paying a little bit more attention. And then are you trying to rescue a pregnancy that was going to fail anyway? It's a very difficult decision for patients and fertility specialists to make. But what I would encourage you to consider is putting everything together. So thinking about the beta HCG, thinking about the endometrial thickness, thinking about the progesterone, and looking at all of those factors together. Okay, another question. Life of Brit, good to see you back. Is AMH that's gone up in the past couple of years a bad thing? Okay. No, AMH does it. although we consider it to be somewhat of an accurate marker, when you look at each age of a woman, there is quite a wide range. So the first thing is, when was the first AMH taken? Was it taken when you're on the pill? Was it using an old assay? So I think it's really, really important to consider that, because the AMH by rights shouldn't go up unless it was falsely suppressed in the previously. We do have a natural decline. If you're talking about an AMH going from maybe a level of 17 to a level of 20, it's probably not a true rise. It's probably just a variability in the assay itself. So I wouldn't call that a big difference. AMH is a soft marker of PCOS, in that we know women with PCOS generally for their age will have a higher level of their AMH. But it's not part of the diagnostic criteria. But by rights, we should see a decline in AMH as we get older, not a rise. Santinus treasures, does the type of follicle stimulation hormone that's used during stimulation have an impact on egg quality and subsequent embryo quality? No, not really. The companies would like to tell you that it does. So there are predominantly two types of hormones that we use. We use FSH, recombinant FSH, and recombinant LH, or its substitute HCG. So the names that you guys would know would be things like gonal F, Puragon, Menopur, Pergoveris, Luvaris. So Luvaris, Menopur, and Pergoveris all contain the recombinant LH or the HMG, which is kind of acting the same as LH. And then the others are just purely the FSH. So all the companies would like us to believe that there is something uniquely different about there's another one, Recavel, that they would like you to think that they all do something different, special. But the reality is they're all pretty much of a muchness, except the ones that do contain the LH component, where some people are probably a little bit deficient. Hope that was helpful without giving you a full-on REI lesson. Jess, what would you recommend if you have done tube clean, trigger shots, open tubes, ovulating every month? Oh, I think I understand what you're asking me. You have patent tubes, you have induced ovulation, so you've done ovulation induction, and you're not falling pregnant. I'm assuming also sperm's normal, because don't forget there's two people at play here. It probably would be IVF, but I would need to consider your entire history before making a call on that one. We certainly know the success rates with IVF are higher than with ovulation induction, but it depends on what your problem is. Emma Green, HRT versus low dose stim with trigger versus natural cycle, pros and cons. Oh gosh, where do I start? The reality is the pregnancy rates are the same. That's the reality. It comes down to personal preference. It comes down to access to drugs. It comes down to needle phobias. But the true reality is you're probably going to have more monitoring with a natural cycle, because we're trying to determine exactly when you ovulate, because we have to time the embryo transfer. And that's why some people choose HRT, because it's really easy to time the embryo transfer. In fact, you yourself can choose the day. So I think there are lots of pros and cons to either, and I would definitely discuss what you would prefer with your fertility specialist. Okay, I'm going to answer two more questions. Burke Megan, does PCOS increase the chance of miscarriage? Actually, yes. There is an increased rate of miscarriage with PCOS. Lots of different reasons. Probably don't have the time to go in, but yes, you can have an increased rate of, my pleasure, of miscarriage. Jess, you've done everything and nothing working. Definitely go back and see a fertility specialist. All right, guys, I think that's it. There's some familiar faces that I have seen on here. Thank you for joining me. I really appreciate it. I'm just going to flick back through and check and see if there are any questions that I missed. Yeah. yeah, let me run through one more time. No more questions. My pleasure. It's always lovely to speak to you. Again, next week I'm going to be that much better again. Another week post chemo, and then I'll only have one more cycle to go. So I will be back with more rapid fire Q&A next week. Love to see you.